Hello guys, the topic of today will be esophageal variceal bleeding. So first of all we will talk about what are the varices. Varices are usually the dilated veins present in the esophagus. What is the cause of it? Usually the increased pressure will lead to the dilatation. Okay, so bleeding, most common site of esophageal variceal bleeding is near the 3 to 5 centimeter area of the gastroesophageal junction. What are the predisposing factors? Predisposing factors are increased portal venous pressure, that is portal hypertension, liver failure, then usage of drugs like non-steroidal anti-inflammatory drugs or salicylates, or the varices are large, then these cases they are more prone to having this bleeding esophageal varices. How the patient will present clinically? The patient will usually present with hematemesis, which may be mild or which may be severe depending upon the amount of blood loss, right? And the patient may present with melena also, but it is not not a rule that patient will present with melena only, right? It may present with melena or it cannot present with melena. Okay, then associated signs will be, so it can be mild postural tachycardia, or it can present with shock also depending upon the amount of blood loss. Associated signs of liver failure, ascites and portal hypertension are usually present. How is the diagnosis made? Diagnosis is made on the basis of fiber optic endoscopy, which is done, and within 8 hours of the bleeding to identify the active site of bleeding, and it is used to rule out the other causes of bleeding also. Then we do the ultrasound also to see the portal veins patency. Then management. So how is it managed? First of all, generally the patient comes to us, we will immediately hospitalize the patient. The vitals are monitored. We will look for the water and electrolyte balance. When the blood loss is usually more, then we will do the emergency blood transfusion, which is the rule, and we should avoid more and more, as much we can avoid giving the saline infusions, right? Emergency blood transfusion is done. If the patient is cirrhotic, immediately the patient is graded on the basis of child Pugh criteria for hepatic encephalopathy. If encephalopathy is present, then the patient is treated according to the routine treatment for hepatic encephalopathy, like giving lactulose and the other things, mannitol and all. So that is the thing. Then the platelets are also less, and the clotting factors are also deficient due to the recurrent and amount of more and more bleeding. So for clotting factors, we will give them fresh frozen plasma or fresh whole blood. We can give them to overcome the deficiency of clotting factors. Then we will give the intramuscular injection of vitamin K also. And the platelets are also deficient. For that, we can do platelet transfusion if to get it above 50,000 per mm cube, right? To avoid the stress ulcers, we will give them H2 receptor antagonists like ranitidine, cimetidine also, and proton pump inhibitors also like pantoprazole or omeprazole, right? Now, if the patient has tense ascites, then we can do paracentesis carefully, or we can give them spironolactone or amiloride to treat the ascites. Antibiotics are also given prophylactically to avoid the spontaneous bacterial peritonitis, like norfloxacin or ciprofloxacin or cefotaxime are used, right? So this is the general management for the patient who presented with hematemesis on esophageal varices. Then what can we do next? So we will try to reduce the portal venous pressure, obviously, because that is causing the bleeding varices. So we will give them vasopressin. How is vasopressin given? 20 units of vasopressin is given in 100 ml of 5% ग्लूकोज, ठीक है, विद इन 10 मिनट्स. इसका और क्या क्राइटेरिया है कि इसको जो है हम ऐसा देते हैं 3 से 4 बारी तक दे सकते हैं, और जो है इसके अलावा इन्फ्यूजन में भी इसको दिया जा सकता है, 0.4 यूनिट्स पर मिनट के रेट से दिया जाता है अंटिल द ब्लीडिंग स्टॉप्स, एंड आफ्टर दैट 0.2 यूनिट्स पर मिनट फॉर अदर 24 आवर्स। ठीक है, अब जो है हम देखेंगे कि कैसे मेरा जो वेसोप्रेसिन दे रहे हैं वो काम कर रहा है कि नहीं। तो वो एब्डोमिनल कोलिक, दैट इज़ एब्डोमिनल पेन लेकर के प्रेजेंट करेगा पेशेंट, फेशियल पैलर हो जाएगा, और इवैक्यूएशन ऑफ बाउल्स। So these are the signs that suggest that the vasopressin is working effectively, right? Adverse effects of vasopressin is arrhythmia and myocardial ischemia, myocardial infarction, angina. To get over these effects, side effects, we will give them sublingual nitrate 0.4 milligram. Other than vasopressin, we can give terlipressin also. Terlipressin is usually inactive but releases the active vasopressin, right? It does not cause the side effects like vasopressin does, cardiac and systemic side effects. So what is the dose for terlipressin? So 2 milligram IV we give, right, 6 hourly till the bleeding stops, and then we give 1 milligram of terlipressin 6 hourly for the next 24 hours. अदर ड्रग्स यूज आर सोमैटोस्टैटिन और ऑक्रियोटाइड। सोमैटोस्टैटिन जो होता है दैट मतलब सोमैटोस्टैटिन एंड ऑक्रियोटाइड जो है दोनों आर सपोज टू stop the variceal bleeding in most of the cases, right? Octreotide is synthetic analog of somatostatin. Dose of somatostatin given is 250 microgram bolus and 250 microgram per hour for 2 to 5 days we give. Drug octreotide is given is 550 microgram of bolus and 50 microgram per hour for next 2 to 5 days, right? So this is done to decrease the portal venous pressure. Now how we will stop the variceal bleeding? So it is done using the following measures. So first is balloon tamponade. For balloon tamponade we can use Minnesota tube we can use, or Sengstaken tube. Sengstaken tube has 3 lumens and Minnesota tube has 4 lumens, right? It has 2 balloons. One is the gastric balloon and one is the esophageal balloon. What we do is we will put the tube inside the stomach via the esophagus only, right? And then we will inflate the stomach balloon first or gastric balloon first, and then we will pull it to the gastric cardiac area, right? And mostly the bleeding will stop. If it does not stop, then we will inflate the esophageal balloon also to have an additional tamponade effect, right? Every 3 hours we should deflate the balloons for 10 minutes to avoid any kind of ulcer, necrosis and other complications or the esophagus, right? Other procedures are endoscopic procedure we can do, like endoscopic sclerosing agents can be put at the bleeding site to stop the bleeding, or we can do the endoscopic variceal band ligation, which is the treatment of choice, right? Other procedures we can do is, if all of these procedures are not working, then we can go for transjugular intrahepatic portosystemic shunt or portosystemic shunt surgeries can be done, right? But the treatment of choice remains as endoscopic variceal band ligation only. If it fails, then we can go for portosystemic shunt surgeries and transjugular intrahepatic portosystemic shunt, right? Then what can we do with recurrent bleeding prevention? So the recurrent bleeding occurs in these patients. Most of 65% of the patient will present with recurrent bleeding within 1 year, right? For this we will give them prophylactically beta blockers and nitrates, all right? Then endoscopic sclerotherapy is also used if the patient is intolerant to the medical therapy. Then we can give them the sclerosing therapy, but the medical therapy is more effective, right? Then endoscopic sclerotherapy is done. And what are the endoscopic sclerosants used? Ethanolamine oleate, sodium orate, absolute alcohol, etc. Injections of sclerosing agents are given every 2 weekly until the varices obliterate, right? Endoscopic variceal band ligation followed with nitrates and beta blockers is the treatment of choice for bleeding esophageal varices, right? देन पोर्टोसिस्टेमिक शंट सर्जरीज, तो इसमें जो है 2 तरह का शंटिंग होता है, एक नॉन सेलेक्टिव शंट, एक सेलेक्टिव शंट. नॉन सेलेक्टिव शंट में जो है वो ज़्यादा चांसेस होता है टू हैव हेपेटिक एनकेफेलोपैथी आफ्टर द सर्जरी, राइट? बोथ ऑफ देम हैव द चांसेस. देन देयर इज चांसेस ऑफ personality deterioration, chronic ankle edema, Parkinson's, cerebellar syndrome, myelopathy with paraplegia. So these are the disadvantages of portosystemic shunt surgeries. So even though it treats the gastroesophageal bleeding, but it will present with jaundice and hepatic encephalopathy post surgery. So therefore it is not the treatment of choice. Primary prophylaxis is done using beta blockers, nitrates, and endoscopic varicose band ligation if the patients cannot tolerate beta blockers also. So this is the topic. See you in the next video.